What can you try to change? Not working. Turn on. Let's turn it off. Okay. Bom dia a todos. Welcome everybody. Good morning. Nós estamos aqui novamente para a terceira e última palestra do professor Joseph Hamill. O professor Hamill vai falar para a gente um pouco sobre o que a biomecânica pode fazer para a prevenção de lesões do ligamento cruzado anterior. Eu quero agradecer inicialmente à Pró-Reitoria de Pós-Graduação, o Programa de Pós-Graduação em Ciências da Atividade Física aqui da Escola de Artes, Ciências e Humanidades, a Comissão de Pós-Graduação e as clínicas de fisioterapia, a MO Fisioterapia e a Fisiopés, por terem nos dado suporte para que o professor Hamill pudesse vir para o Brasil e ter passado conosco esse tempo e ter apresentado esses trabalhos para vocês. Okay. Joe, this is your third lecture. I'm very, very, very honored to have you with us. Not only because you are the only example of former president of the ISB, the International Society of Biomechanics, and International Society of Biomechanics in Sport, but also because what you mean as a person and what you mean for us, I can tell you my name and regarding my name and also Ulysses' name and the friendship that we have for those years. Thank you so much for all you have contributed for us and for our students and for everyone. It's your turn, Joe. Thank you so much. Joe, I think that you need to talk close to the microphone.
Thank you, Luis. It's a pleasure being back in Brazil. For a moment there, I thought you were going to say I was the only one that would come to Brazil, but anyway, what I'm going to present today is a little bit of thought over many years in doing research on ACL injury prevention. And I'm going to go over a number of studies that we've done over the years. And I'll try and give you my final answer to the question. Okay, the problem is, ACL injuries, and particularly non-contact injuries. This was an American football player, and he had this, there's no one near him, he tore his ACL, and his career was essentially over. You can see here, Luis, can you? Yeah. I guess the pointer doesn't work, but you can see on the little diagram on the right, or the left rather, that you know, that his ACL is torn. There's been a lot of injury surveillance, and you know, if you notice, the injury rates of ACL have doubled in the last decade. It's a much more prevalent injury than it ever was before. And 60% of these injuries are non-contact. Okay. And, you know, mostly single leg supporting tasks. And of course, the problem that many people have been working on is the fact that females have 4 to 8 times the risk of getting an ACL injury than males do. Now, there are possible risk factors that I've tried to identify. Hormonal factors and biomechanical factors, those are the ones that I'm going to concentrate on talking about today. But structural factors fit in with hormonal factors, and neuromuscular will also fit in with biomechanical factors. This one is I will not talk about specifically. Now, in terms of hormonal factors, estrogen receptor sites are in the ACL itself. Decreased collagen synthesis within the ACL with increased exposure to estrogen. So those two factors seem to indicate that the ACL is an important site or a prominent site for injury. Estrogen effects on collagen may be encountered by the opposing effects of progesterone, which means that there are certain times of the menstrual cycle when females may be prone to ACL injuries. And of course, you know, males don't have the menstrual cycle, therefore, you know, that's why people think that there's an increased incidence of injury in females. Now, the first question that we asked was, does estrogen affect the structural characteristics of the ligament? And what we said was, well, if it does, then it might affect ligament strength and ligament elasticity. So in terms of ligament strength, chronic exposure to cycling estrogen may alter the female's ability to remodel the microtrauma placed on the ACL after exercise. And so you get something like this, that increased serum estrogen decreased the load to failure. So if you look here, this is a cartoon of a ligament, okay? And when you stretch the ligament a little bit, it lengthens, but when you continue to stretch it, it gets to a point here in what we call the plastic region, and then gets to the point here that refers to the failure rate. Okay. Now, this is a cartoon again of the menstrual cycle, and there's a possible relationship between knee laxity and the reproductive hormones. Estrogen increases the distensibility of the joint structures, which may account for ACL laxity. So you see, as estrogen at the beginning of the cycle goes to the ovulation phase, here it's much greater than progesterone in the cycle. And therefore, you know, there's a possibility that during that phase, up until ovulation, that females are prone to ACL injury. Now, one of the methods that we used was a very simple method based on that physical therapists use just about every time they're evaluating the knee, and it's called a KT arthrometer. And here you see the experimenter using the KT arthrometer, and what it does, you hold the femur constant and then displace the tibia. Tibia displaces a great deal. There's a great deal of laxity in the ACL. If it doesn't displace it very much, there's not very much laxity. But what we did was we looked at the KT measurements while the patient was free, that before exercise, and then we had them go through an exercise protocol, as you can see there. And when after the KT arthrometer measurements after the exercise, we did a blood draw, and the blood draw was to evaluate the levels of the circulating hormones in the blood. And so these are the results that we got. If we look at estrogen across the menstrual cycle, of course, there are different phases of the menstrual cycle. And you can see that it does increase during the follicular phase, which is the phase leading up to ovulation. If you look at the progesterone, it doesn't increase until the luteal phase, which is the phase after ovulation. Now, if we combine those and look across the whole menstrual cycle, across all phases, what we found that there was no difference in laxity. Now, these were healthy females, okay? They were athletes, but the ACL was not a worry to them, or at least yet. So what we think the etiology of this whole system was we've looked at in vivo, excising the ACL from cadavers and doing different stress tests on it. We've looked at in silico, which means in the computer, doing modeling. And we've looked at ex vivo, which is the kind of biomechanical tests that we would normally perform. These are all of the ways that we've studied ACL. The thing that has dominated the literature is that the flexion moment, the valgus moment, and internal rotation moment, if they're elevated, it appears that those people are at risk for ACL injury. And what we found is that the peak knee valgus, that is the side-to-side movement of the knee, and internal rotation moments are 2 times higher in what we call unanticipated sidestepping. Sidestepping is just a run and a change of direction. Now, the big question is, why do females have more injuries than males? And you can see here the diagram at the top. This just shows you, 1 in 12 males get injured versus females. The graph on the left here is look at men versus women across different age groups. And you can see that women in this age group, say from age 15 to age 25, have a very, very high incidence of ACL injury. Well, that makes sense because that's when most women are participate in sports. But you notice it drops off drastically after that. And mainly that can be because the women are just not participating in sports in the same numbers. Whereas the male, it seems to hit a peak around age 20, and it flattens out to about age 39 and then decreases after that. So the males tend to participate in sports longer than females do. Now, this is the injury incidence in collegiate sports. This is university level sports. And you can see that if you look at injuries per 1,000 player hours, females have far more injuries in basketball and in soccer than do males. That's just a fact. The problem is why? So why are they at risk of injury? Well, people have suggested that the Q angle, the angle of the femur relative to the hip width. In other words, if you have a greater hip width, you possibly have greater Q angle. In males and females, it's slightly different, and that may be a cause because it puts the knee in a valgus position. The other one is a structural problem, and it's called the intercondylar notch. And people say that women have a smaller intercondylar notch, and therefore, when you flex or put the knee into valgus, this intercondylar notch acts like a guillotine and cuts or frays the ACL. That's still questionable. And then there's the whole problem of the circulating hormones. So all of these factors, you can't modify them. But there are other factors that you can modify, which may influence these particular factors. Hewitt in the United States tried teaching people or teaching young girls how to land from a jump. And he called this neuromuscular retraining. And then there are several other researchers did what they call lunge jumps. And this was, again, a kind of retraining. And then, there's some of the things that we've done and others have looked at this whole notion of sidestepping because, it puts a great deal of stress on the knee. So these are the bottom are the things that we can modify possibly, and the top are non-modifiable. So what are the influences of both gender and exercise on anterior knee laxity? Well, these are the results. And generally, I can sum this up in two statements. Females demonstrated greater laxity across all conditions. Even before exercise, females had greater laxity. And females exhibited a higher laxity, level of laxity than the males ever reached. Okay, so that may be a situation that would influence the possibility of an ACL injury. And looking more at this, could these differences be attributed to a chronic exposure? Like this exposure to estrogen is every month in females. And so over the period of time, say years, during having a menstrual cycle, it may be chronic and build up this estrogen level. It also could be an exposure to an environment that is collectively causing rhythmic structural changes. So with all of this chronic exposure, it may be inducing chronic structural changes in the ACL. These are all possibilities. So the question is, if the ACL is more distensible, that is, stretches more, during lower extremity dynamic tasks, is it able to protect the knee and provide the necessary stability in order to prevent injury? And it's been associated and suggested that increased joint laxity is associated with decreased joint proprioception. And maybe it's the combination of decreased stability coupled with decreased proprioception that places the female athletes at a greater risk of injury. In other words, the females cannot recognize when they're in an extreme position, whereas males possibly can. Now, like I said, this is all supposition. It's not fact as yet. Now, we went on to do several papers on sidestepping. And this was the first one. And it was done by my postdoc at the time, Gillian Weir. And the Stillman was she was an athlete, and she was an honors student in our laboratory. And the rest of us were just hangers on. But what we tried to do is evaluate kinematics, kinetics, and muscle activation strategies between males and females from team sports during unanticipated sidestepping. And what we thought would happen is what was in the literature, that there were elevated, the women would have elevated peak knee moments. There would be differences in the hip and knee kinematics, and there were differences in the muscle activation strategies. So this is the way it was done. We used University of Massachusetts male soccer players and female hockey players. Because we chose that because they were comparable in terms of their activity. And these were all the best athletes in these sports at the University of Massachusetts. The experimental setup, we used 43 marker setup, and then we had muscles applied, EMG applied to various muscles, and you can see the muscles there. And we had a protocol that was was unanticipated. Now that means as the person approached the target, they didn't know whether they were going to run straight through or veer off to the side or stop. So when they saw that, they had to stop on the force platforms. When they saw that, they had to cut. And when they saw that, they had to run straight through. Now, they were approaching, this is where they got the signal, which was approximately about 1 meter before the force platforms. And they had to approach the running speed at 4.5 meters per second, which is fairly fast, in order to do this particular task. We had many of the graduate students in the lab try to do this, and they couldn't do it, but the elite athletes could. So there's the cut. Okay, so the way we analyzed this, we used a statistical method called statistical parameter mapping. And what that allows us to do is look at the whole time of the event and not individual points in the event. And so we looked at hip and knee kinematics, and our hypothesis there was externally applied knee joint moments would be higher. And in fact, they were. We looked at, in the EMG, we did what was called basically Co-Contraction Index. And there, we looked at, you can see the quadriceps, hamstring, and gastrocnemius co-contraction. Okay. Now, these are the results. Interestingly enough, we found no difference in valgus moments or internal rotation, but we did find moments in flexion. What basically happened was that the women were at a more extended or less flexed knee position. Now, if you that will influence the valgus and internal rotation. So in terms of the kinematics, when you see the dark bands there, that indicates the positions where there were significant differences between men and women. What you can see there basically is that for most of the angles, there was very, very little difference, except in the flexion extension. And that period where it was significantly different was the period in which they were actually performing the cutting maneuver. So females had lower hip flexion, greater hip abduction, and greater internal rotation during early and mid stance. The muscle activity, well, there were certainly differences in the activation between males and females. You can see in the gluteals, the quadriceps, and the hamstrings, and the gastroc, the males had greater activation. The interesting thing is in the looking at the directed co-contraction ratio, the females had zero co-contraction, essentially. And males had a large amount of co-contraction. And we hypothesized that that would probably, this large co-contraction would probably stabilize the knee joint, okay, and protect them against an ACL injury. So what's the summary in this particular situation? Knee valgus and internal rotation moments were not particularly different. And there was a slight difference in knee flexion moments. The women had increased hip adduction and internal rotation moments and decreased hip flexion moments. Now, all of these, you know, we always think if we're looking at a knee problem, we should study the knee. If you're looking at any problem, you study the whole system, because the knee will affect the, the hip will affect the knee and the ankle will affect the knee. And there was significant gluteal activation in the females. And the co-contraction, I've already said, was almost non-existent in the females. So the next thing that we did was whole body control. Now, we weren't necessarily looking at what the leg was doing, although, you know, it was important because we're still doing a sidestepping, but we're looking at now essentially the trunk, because the trunk is the largest mass in the body, and you have to control the trunk in any activity. And this was done by another former postdoc, Hannah Wyatt. And what we looked at was the different directions that the trunk could occur during the movements. And you can see we looked at the anterior posterior, which is the direction of motion, the medial lateral, side to side, and the vertical, that's up and down. And you can see that in each one of these, the males did it slightly different than the females in controlling their upper body. If you notice, the one that's most dramatic is the medial lateral. If you notice that what the females did was they did this kind of action. They tilted their body in order to keep their center of mass basically over the base of support. What the males were able to do was to keep their body fairly upright. Now, you could infer that the males had stronger core than the females, and that possibly may be true, but they did it differently. And in each one of these situations, the posture could lead to you know, extending the ACL and possibly tearing the ACL. So the use of whole body focus for training athletes is really very important for females or for coaching. It's easy to see what the trunk is doing as you're doing any of these tasks. And the importance of training focus on the early reorientation of the center of mass towards the direction of travel. Now, we get into another area of coordination. And this particular study was done by a former PhD student, Christine Pollard. And she was a PT. And if you notice here, I've just chosen two of the couplings to talk about. But if you notice here, in both of these couplings, there was a significant difference between 0 and 40% between the males and females. Now, why is 40% important? At the 40% mark in these trials, that was where the person started to make the cut. Okay. And here, in both instances, the females had lower coordination capability than the males did. And it's the same in these two other couplings. Now, how do you interpret this? And this is the way we did. that in any activity, you have several different ways of doing the activity. In other words, you have multiple degrees of freedom and you have a goal. And so the males were able to utilize all of these patterns. The females, on the other hand, that had lower variability may not have been able to utilize all of the patterns, maybe some of them, and thus the variability in the motion was significantly reduced. And with a decreased flexibility, well, with a decreased flexibility, that may have led or could have led to an injury. So if females exhibit this less flexible pattern of coordination, they have a decreased ability to adapt to frequent external perturbations. The more options you have in moving, the better. So here we have this situation in females. Decreased coupling patterns. The goal is the cutting task. Decreased flexibility. And then you add an external perturbation, and it may result in an acute injury of the ACL. Now, where all of this came from was a paper that I did in, well, actually, the original paper was done in 1999, and it looked at variability and injury risk and coordination variability. And I maintained then that lower coordination variability indicated an injury. Higher coordination variability indicated a healthy state. That was very controversial in 1999. Now, we modified it slightly because we realized that you could go to too high a coordination variability. That could also lead to an injury. Too low could lead to an injury. So you have to be right somewhere in the middle. That with a high coordination variability than the low, but not as high as the really high variability. Now we have to differentiate because, you know, you see in the literature many times where they talk about high variability as being bad, you know, or high variability as being an indicator of, some pathology. And the thing is that there are really two kinds of variability that you have to look at. One is coordination variability, in which high variability is probably a good thing, but not too high. And then endpoint variability. And endpoint variability refers to the end product of what the coordination variability indicates. In other words, if we look at step length and stride time or approach velocity, they're all the end products of the kinematics and the coordination variability. So in this, in endpoint variability, you would really like to have low variability. Okay. Low variability would be good. Coordination variability, these are trial-to-trial deviations in the segment movement patterns. And you want higher variability to indicate flexibility of the system. So now we get into a situation where we looked at anticipated versus unanticipated. In other words, as in the last time, they didn't know what they were going to do until about a meter before the platforms. Anticipated means we told them before they started, do this. Okay. And what we suggested was coordination patterns would differ between the tasks, and that the coordination variability will be lower during the anticipated versus the unanticipated. And again, we use the UMass soccer players. I guess in Brazil, you don't normally have soccer players wearing hats and tracksuits during training, but this was Massachusetts. And we used a similar protocol as I presented before. And we looked at multiple joint couplings. These are all of the ones that we looked at, and we looked at these over the stance period. Now, we used a technique called vector coding, and Robert Needham and I developed this. This is a further extension of the original vector coding. And when you calculate the vector coding angle, you can look at proximal segments and distal segments, and you can tell whether they're in phase or anti-phase. And so based on the rotations, you can see is the distal segment dominating the movement, or is the proximal segment dominating the movement? And so this is the kind of thing that we would look at. And you can see this is just the joint angles of the hip, knee, and the coupling angle between them. And then we looked at the coupling angle frequency in this. And we also looked at the endpoint variability. And thankfully, there were no differences between the approach velocity and the contact angle and the cutting angle. There were no differences in those. So all of the variability should be in the movement variability or coordination variability. And so we looked at these in the 3 planes, and we had greater in-phase trunk variability, greater in-phase trunk lateral flexion, pelvis obliquity coupled motion, but there was no difference in between rotation. And looking at hip knee, we found greater in-phase hip knee flexion and greater in-phase hip knee rotation. And again, if you look at these, the coordination variability, the bands indicate where they were significantly different. And really, you can say here that there was no difference between anticipated and unanticipated. Okay, and this is 2 other couplings. So what we came up with here, as the task complexity increases, coordination becomes more in phase, and the variability increases regardless. So even in the unanticipated, where they knew what they were doing, it's still a complex task. And what are the implications for injury prevention? Unanticipated sports tasks for screening and training. In other words, there is no use in, or we don't feel there's any use in telling a person, okay, just run and make a cut. You know, what you have to do is make it an unanticipated situation and make it the situation that they would actually do that in during practice. And the other thing, and again, this is where we have extended our research into the role of perceptual training. What's happening during head movement as you're doing the task? What are you looking at? And we've extended this particular task not only to unanticipated, but we gave them a target that came on as they were doing the cut. And we asked them, what are you looking at? You know, can you see this target? And of course, those results were just published actually in Human Movement Science recently. So this is Gillian Weir's notion of an injury prevention framework, that injury surveillance, look at the etiology, and develop countermeasures. Then you would do athlete screening, do a training intervention in the ideal world, do a training intervention in the real world, and then in the community. And if this doesn't work, you go back and try again. One interesting point that you have to be very careful of, and this is using group data. This is actually happened in our study. And we looked at the peak hip internal external rotation angle. And if you look at the males and females, the average was, just a little above 0. But what you notice is that you have as many males above average as below average, and you have as many females above average and below average. Sometimes the mean could be not tell you the true story, because in this you would say there were no differences, but in fact there are. And so it's always good to look at the mean, but also look at the structure of the individuals. Okay, and the fact that these 3 males deviated were different from the rest of the males, it increased the male group mean by 3.58 degrees, which is a significant amount. In other words, 4 males as compared to 7 females demonstrated greater peak IR values than the male group mean. So what's the take-home message of this whole talk? Will biomechanical approaches to injury prevention be successful? At the present time, I don't think so. I think the answer is no. What we have identified, which is good, is risk factors. Okay. Now, the thing to understand, though, is if you have a risk factor, it doesn't mean that you're going to get an ACL injury. Okay. Because remember, there are modifiable things that you can do, which will alleviate the having this risk factor. And I really do think that screening for risk factors and training to attenuate these risk factors may be a critical factor in reducing ACL injuries. So there was a number of people who were involved in all of these studies. Going from the left is Gillian Weir, postdoc, Richard Van Emmerich, professor, Hannah Wyatt, postdoc, Carl Jewell, PhD student, and then Christine Pollard, former PhD student, Brian Heiderscheit, former PhD student, Irene Davis, friend and colleague, and we worked together, and Barry Braun, who was a faculty member at UMass at the time. And then the research assistants, starting on the right is Denisa Blašková from the Czech Republic. In the middle is Melanie from England. And then on the left is the best one of all, my granddaughter, Alexis. She worked in my lab all during her undergraduate career, although she did not like it, but she liked the money. Anyway, thank you very much for listening.
Thank you, Joe. Now we are open for questions. Who would like to make one? Yeah, I think that's better.
Yeah, I have 2 questions, which are probably more directed to the neuromuscular side of ACL injuries. The one is about the popliteal muscle, because we're talking often about the big muscle groups around the knee, and the popliteal is often referred to the proprioceptor of the knee and also stabilizer. If there's some research about this. And the second question would be about cognitive or mental fatigue, because we were talking about the perception and cognitive side as well. And I can imagine that there's maybe some influence also when we talk about game congestion, training load, and that injuries occur with cognitive fatigue.
Well, I'll answer the second one first. We have not really concentrated on cognitive fatigue, although we acknowledge that is a problem, but cognitive fatigue is hard to evaluate in a lab situation. And I don't think we're at the level right now of acknowledging cognitive fatigue as a risk factor for an injury. As I said, we're trying to move up in terms of even perception. What happens to your perception during these movements. And the second question, the popliteal muscle, it really doesn't influence the movement very much of the knee. It's more like it works with other muscles. And it's also very hard to, get an EMG signal from. And the other factor that's even more interesting is that not everyone has a popliteal muscle. So we really have not done anything with it.
No, thanks.
Thank you again, Professor Hamill.
Can you speak up, please?
Sure. Thank you again for amazing presentation. Sometimes we associate the high peak and ground force and floor from the ground reaction force to increase injuries. Can we some strategy reduce the ground force or the ground reaction force, however, increase the torque and the joints, and of course, in this case, increase the risk?
In activities where you increase ground reaction, or the increased ground reaction forces occur, as in landing from a jump, or increasing your running speed, humans have a remarkable ability to adapt. The only time that those high forces of the ground reaction forces become a really significant problem is when they're unexpected. Like if I was walking along and I didn't know there was a big drop, I would not use whole body kinematics to attenuate the impact. But if I know, then what I'll do is, I'll have increased flexion of the knees, increased flexion at the hip, and that will help to reduce the impact forces. So, humans, unless, as I said, there's a significant lack of knowledge of the situation, then, the forces will it could cause injury. An example that you're probably aware of is if you're walking along and there's a curb on the road and you step off the curb, but you don't know what's there, and you hit your heel and you can feel your teeth chatter. That's an unexpected situation. Now, if you can imagine that going off the stage here, the force, you could deal with that stepping off the curb, even though that force radiates all the way up through your body. But this one, it would radiate up through your body too, but with more disastrous effects.
Nice. Thank you.
Joe, you showed some comparisons for time series analysis, and you were discussing that idea yesterday, the SPM analysis. But by the end of your presentation, you had also stressed that we also need to look at the persons individually.
Yes.
Have you tried to look at the time series, not the mean or not the sample average of the individuals, but each trial to trial, and see if the differences between groups remains at the same time or changes for person to person?
You can do that in SPM. SPM is like any, parametric statistical package. You can do repeated measures. You can do, multifactorial. And so you can do that and look at the effect of each individual. And I always encourage my students and postdocs, don't stop with the statistical results. Look at each individual subject and make sure that there's not something weird going on. Like you may have all of the subjects clumped here and one subject up here, and that subject really influences the mean. And so, you have to do something about this one subject. Or, you may have 2 or 3 subjects all varying in different ways. As I tried to show you at that last slide, there were 3 male subjects that didn't operate the way the other males did. So that one. I encourage my students and my postdocs to really, really, really look at their data. Don't stop but look at the mean, because there may be something funny going on that you're not probably aware of.
And for this case, well, we know that your group is not big enough, but could we think that we have in fact 2 subgroups? I mean, the ones who goes up, and the ones who goes down, and I don't know if you have checked their individuals' characteristics to see if they have some similarities, the ones who goes up and the ones who goes down.
No, we didn't. In this particular paper, we just pointed out this fact. And this paper was one from 2005, I think. Now I definitely would have tried to create subgroups. I don't know if you remember Sandra Aliberti.
Yes, yeah.
Her results came out very similar to this. She had a small total group, but within the small total group, some of the subjects did this and some of the subjects went down. And in fact, what she put in her thesis was the fact that these subjects, while they had the same problem, were using different strategies. And that's very, very important. Unfortunately, reviewers look and say with this, oh, you've only got 7 subjects.
Yes, yeah, I remember that.
And that's bad on the reviewer's part. They should acknowledge what the data mean. And I don't know if Sandra ever got the paper published, but it was a very, very excellent paper. So,
okay.
But you're right. At this time, we should have broken it down and looked at what makes these subjects different.
Yes, yeah. Well, pessoal, quem está online no Zoom, alguém gostaria de abrir a câmera e comentar alguma coisa, fazer perguntas?
Mochi, bom dia, tudo bem?
Espera aí. Ju.
Oi, eu gostaria de fazer uma pergunta, mas acho que não vou gastar meu inglês tupiniquim, aí você me ajuda traduzindo?
Claro, pode deixar.
É o seguinte, eu compreendo que pela complexidade do esporte existam muitos movimentos inesperados e que aí realmente é difícil pensar em alguma intervenção para prevenir a lesão nesses momentos, mas...
Peraí, don't follow. She's saying that in sports, it's clear that there are a lot of different unexpected movements, but...
Mas os movimentos que ele analisou no laboratório, como o salto e as mudanças de direção, já apresentam algumas mudanças que podem ser modificáveis pelo treino, tanto pelo treino de força, como pela melhora na técnica do salto, ou para ensinar como fazer uma mudança de direção melhor, e tem estudos que evidenciam que que tem como melhorar essa técnica e que provavelmente isso pode impactar numa diminuição do risco.
But and she said that, for example, for jumping and for the example that you showed and you have measured, also there are some studies showing that you can do some intervention and do some exercise training in order to prevent those problems.
I agree with that. That's what I was suggesting you could do.
Então, a minha pergunta é se ele acredita que ainda assim tem como diminuir o risco de lesão com essas intervenções, mesmo que para movimentos que sejam extremos e inesperados, isso não seja possível.
And now she's, well, okay, that we can do some interventions for what we know, but there are some unexpected movements during sports that we are not measuring and it's still happening.
Mm-hmm.
So is it possible to extend your conclusions into this whole variety of unexpected movements that we have in sports?
I would not like to do that. My interpretations are based on my data. Now, I acknowledge that in most sports, there are a lot of other things that occur that are unexpected movements and, result in injuries. But, you would have to look at the etiology of the injury during that technique. It's really difficult, say in a sport like soccer, to analyze every conceivable movement that a player goes through during a game. But what you do is, or what a good trainer would do, is try to go through and rehearse the kinds of movements that they would do most often. And sidestepping is one of the movements that they do a lot. So the other thing too is doing these movements slowly doesn't help. I don't think it helps. I think you have to do them at full game speed all the time.
Mais alguma coisa, Ju?
Acho que é isso, Muxi. Então a questão é, dá para diminuir o risco, só não dá para acabar totalmente com a probabilidade de lesão. Acho que é isso, né?
Mm-hmm. Juliana, she's one of my PhD students.
Oh, congratulations.
Thank you.
And because Juliana and Kiel, they are working with the data bank that we have from Biodex evaluation of the knee, and we are trying to find some subgroups within all the patients from ACL surgeries that they have in the hospital to see if it's possible to find any relation between the Biodex information and their recovery through time.
Yeah. One of the things that I've come to the conclusion that every human is unique and different. And when we say we have a homogeneous group, we really don't. In fact, like if we have 10 subjects in our group, for example, there's a distinct possibility you can have 10 different ways of doing the same thing. Okay, and you have to be aware of that. Grouping sometimes hides the message.
Yes.
And this is why I'm so adamant with my students of looking at every individual, look at the values of every single individual and make sure, that they're comparable. Well, they're not going to be comparable. They're going to have a standard deviation, but at least are they all in the same area? If they're not, then you do have, subgroups, and you have to deal with that. At the time that I finally discovered this, I'd already published a whole series of papers and couldn't retract the papers. So,
but then now you can publish more of the papers.
Yeah.
Pessoal, alguém do Zoom gostaria mais de falar? Shida.
Hi, Professor Hamill. Congratulations for your presentation. I'm very interested about your research. And nowadays, I have been working with older adults. And I have a question for you. Do post-menopause women have the same frequency of ACL injury than older men?
I don't know. If you look at the graph, one of the graphs I showed over age, there was a slowly decreasing number of ACL injuries. I don't know what the mechanism is for ACL injuries, period. And I certainly don't have any clue about what happens. Is the mechanism different for an elderly person and a younger person? I tore my ACL about 5 or 6 years ago. And all I did, I slipped on a piece of linoleum, a tile, and tore my ACL. I would hope that if I was much younger, I wouldn't have torn my ACL, but I did. But I don't know. I can't answer your question.
And Professor Hamill, we are talking about ACL, but another ligament, for example, the shoulders ligament. Do you have any clue about the difference between younger and older adults, for example?
I really, that's not my area of research, and I wouldn't like to speculate.
Okay, thank you very much. It's an interesting area to do some studies, I think. Thank you very much.
Thank you, Shida. Obrigado, Shida-san. Arigato. Alguém mais gostaria de fazer alguma pergunta ou fazer algum comentário, né, sobre a apresentação? Não?
I have one more question regarding what you said, that we have to look at individuals and subgroups. And so when it comes to screening the athlete or screening some person and also training them becomes quite difficult then, because, like, as you said, can be very individual. And so probably, or for sure, with general screenings, we will lose also patients or athletes which will later have an injury. Do you have any suggestion how to address this, or like how to be more flexible maybe in testing and training?
Well, I mean, what are you screening for? Are you screening for an injury? Or are you screening to put them into your study?
Yeah, for example, pre-season, I'm gonna screen the athletes in order to see how to adapt the training. Well,
you should screen all of them, because they are all going to be individuals, and you have to screen everybody.
I'm just thinking about that, if the screening then is sufficient, because it looks at just a number of factors, a number of kinematic factors or strength factors. And we know that there are a lot of unexpected things we were talking about today. And so therefore, I'm just worried about, or maybe we just have to accept that there will always be a certain share we will not see and not predict. But I don't know if you have any other suggestion.
I mean, you know, like if you think about the studies that Hewitt was doing with young women, teaching them how to land. You know, let's say that landing was one of your tests that you were screening for. And so, you know, what you would look at is certain parameters where they were going to attenuate the forces, have the knee in the proper position, not land in a valgus position. Those are the kinds of things you would screen for. But you would screen everybody and not worry, you know, they're all individuals. So they, when you're screening pre-season, there are no groups. The group is the whole thing, everyone. So that's what I would do.
Thanks.
Laura, eu vi que você abriu a câmera. Você quer fazer alguma pergunta?
Bom dia, professor. Eu sou aluna de mestrado da professora Karine, da Unicamp, Vou pedir desculpas por também não gastar o meu inglês, eu já estou sem graça de estar me comunicando aqui, mas enfim. Professor Hamill, eu vou estudar na minha dissertação a influência de uma força externa em tronco de mulheres com desalinhamento de membro inferior. E seria uma pergunta bem técnica. A princípio, eu estou pensando em usar o tronco como um segmento só. Você acha que seria interessante eu, até pensando em subgrupos na coordenação dessas mulheres frente a essa força externa que eu vou exercer em tronco, segmentar o tronco em mais de um segmento?
She's going to study the effect of trunk posture into lower limb movements. But her concern is if she should or not consider the whole trunk as one solid, or she should segment the trunk in two parts, and then study the coordination between the part of the trunk and the lower limb.
Well, in some of the studies, we've looked at the trunk as a single unit. In others, we've looked at the thoracic spine and basically ignored the lumbar spine because we were interested in rotations. And 90% of the rotation in the trunk occurs in the thoracic region. So it depends upon your question, what you're trying to do. To be on the safe side, like for instance, I would do both, look at the thoracic region and look at the trunk as a whole. But I don't know the question. I'm just.
Ele está perguntando qual é a sua pergunta, Laura, de pesquisa.
Eu quero ver se eu consigo, com uma força externa rotacional em tronco, mudar o comportamento do membro inferior com relação à adução femoral.
Isso na marcha.
Desculpa?
Isso seria na marcha? No andar?
Não, durante saltos unipodais.
Okay. Her correct question is if trunk rotation changes the external forces and also change coordination in single jump when jumping with just one foot.
Well, if she's interested in the rotation, I would just definitely concentrate on the thoracic region.
Tá certo, obrigada.
Alguém mais gostaria de fazer alguma pergunta, pessoal? No? Well, if we don't have any more questions. Joe, thank you again and again and again. So it was so good to have you here in Brazil for these 3 lectures you gave. All those lectures are on YouTube. If you want you to see, or if you want Donna to see you that you were here. And it was a pleasure to have you here. And all the students, thank you for your participation here, attending for all these presentations. And now we're gonna finish. Okay. Joe, would you like to say some few words to finish?
Well, I would just like to thank you and USP and everyone who attended the lectures. It's always a great thrill to come to Brazil and to present my work here. So I appreciated very much the invitation and the hospitality that I always receive here. Thank you.
Well, I can tell you that we had more than 100 people watching you along the days and your presentation. So you had a great audience. Thank you, Joe.
Thank you.
Bom, pessoal, muito obrigado por terem ficarem aqui conosco, né? Então agora a gente vai terminar a transmissão, né? Quem quiser rever as apresentações, elas estão no YouTube, tá bom? Tchau, pessoal, tenham um bom sábado, uma boa semana. Fiquem bem. Tchau.